Good afternoon, everyone. Thank you for coming. And I'm going to introduce Dr. Christopher Brown. He is our infectious disease specialist here at Campbell County Memorial Hospital. He'll provide some remarks, and then there'll be an opportunity to ask questions. I would ask that you use the microphone. We'll have a handheld mic for you to ask your question so that it can be picked up and recorded as part of this event. Without further ado, Dr. Chris Brown.
Good afternoon. My name is Dr. Brown, and I am the infectious disease specialist. I'm employed here at Campbell County Hospital. I'm going to talk to you and answer as many questions as I can about recent events involving 3 very serious group A streptococcal infections in this community from about mid-August through mid-September. I'm going to say a few words first and then help you best I can with any questions you might have, and I'll certainly be available later as well. I was out of town during the time these cases were cared for in the hospital, so I don't really have personal experience with them. However, as the infectious disease specialist here, I have reviewed the cases in detail. I've spoken to all the physicians involved in the care of those individuals, be the care here or in outside institutions. I've spoken with our local public health officer, Dr. Patel, as well as the state public health officer. And in addition, I've spoken with the chief of infectious diseases at Harvard, who led us to Dr. Dennis Stevens, who is considered the world's authority on these types of infections. I've also spoken to Dr. Musser, who's chairman of pathology in Houston, who's the authority on tracking, identifying, and trying to follow infections of this type. Before I talk about these particular infections, I have to remind you that all of us are bound by what are called HIPAA requirements and HIPAA regulations. HIPAA is law that states that we, as medical professionals, really are not allowed to and should not divulge information that might invade someone's privacy. And that means that I will give you generalities, I'll tell you as much as I can, but I'm not to give identifying information related to individual patients. I'm sure you understand that limitation. Within the last month, starting mid-August and going through about mid-September, Campbell County has had exposure with 3 streptococcal infections. These are group A streptococcal infections, all 3 quite serious. 2 of these infections could be classified as necrotizing fasciitis, and although a lot of us don't like the term in the lay press, people talk about flesh-eating bacteria, which is not an accurate term, but they were serious streptococcal infections that will infect the tissues and cause a significant amount of damage. One of those individuals, I'm allowed to say, did pass away, did die as a result of this problem. So 3 cases. 1 case would not be classed in terms of medical parlance as necrotizing fasciitis. It was a very serious infection. It was group A strep, but it was not necrotizing fasciitis. I can also tell you that 2 of the cases that were necrotizing fasciitis, they were closely linked in terms of having close contact on a regular basis. That means that the index case, the first case that develops the disorder, can potentially transmit to very close contacts, and in this case the contacts were very close. So that's pretty much the situation on those 3 cases. Since that time, everybody has kept their eyes and ears open, including the state. There has not been, to our knowledge, any additional case or cases. I can tell you that it wasn't, I think, more than an hour and a half ago that as I was getting ready for this and talking to some other physicians, I was handed a piece of paper about the article in paper about the dog. I don't know if you're already familiar with that. So I spoke to Dr. Lind, who was very forthcoming. He's the veterinarian involved in that case. That was not a group A strep case. That was what we call a coag negative staph. It's a bacteria, and without a doubt, it caused a very serious infection in that dog, but it's unrelated. So, now a few other general comments based on my review of the cases. And speaking with others, the question has come up about where these originated. Group A streptococcal infections, generally speaking, I mean, they're actually relatively common, but the vast majority are not terribly serious. The strep throat that we all hear about, that's a group A streptococcal infection. There are other types of group A streptococcal infections. These serious infections tend to be quite uncommon. They're quite uncommon. They appear to be increasing, at least in this country, in frequency somewhat, but still with the increase in frequency, they're uncommon. The general risk to the population is considered low. There is considered to be some additional risk of very close contacts, and in the literature, the medical literature, there have been documented cases of close contact transmission. And by that, I'm talking about usually family members and or medical caregivers. Medical caregivers, physicians, nurses, technicians who are in very close contact with the case. Although standard precautions are the best defense, and that's what's pursued, but occasionally there are transmissions to close contacts. And we think that in the second instance, the transmission was to a close contact. When these serious infections occur, and we've all seen them, not just infectious disease people, but surgeons in particular have dealt with them, they don't tend to come in epidemics, and they tend to come in isolated single cases that occur sporadically, and they tend to occur from the community. For what reason, nobody knows. Clusters are also reported. We would refer to this as a cluster, a small grouping of cases. But clusters are also infrequent, and clusters will pop up and tend nothing else happens, generally speaking. But certainly here at Campbell County, we take this very seriously, as do the public health individuals, and based on recommendations from the gentleman who we've spoken to, who are the world's expert on these organisms, we will be doing some organism typing and doing some trying to do some tracking of the organisms, although we don't really expect a big problem, but I think it's appropriate under the circumstances. I think that's probably pretty much what I'd like to say about those cases and about group A strep infections in general. Again, it does not look on review of the cases, those infections did not originate here. They did end up here because those people got sick. They were community acquired. They originated in the community. So I think I'll take any questions you have. Hopefully I can help you. Yeah, yes, sir.
How will you go about notifying the media or public if there's any more cases reported this year or early next year?
Well, that will be it's a good question. I think if the public needs to know, because these infections, if you're not a physician, they sound scary. They are serious infections. They're not common, but I think within the guidelines of HIPAA restraints, I'm sure there might be some mechanism, but probably should happen through public health. We work closely with Dr. Patel and his counterpart in Cheyenne. And in fact, the typing, we're sending these organisms out. We have organisms for 2 of these cases. We don't have them for all 3 because the first case, organisms are kept for a particular period of time and then they're discarded, in the culture. That's routine. we chose to ask the lab to keep these cases that we still have, and those were the two necrotizing fasciitis cases. So they're being sent out for typing by Dr. Musser's group, and as soon as we have that information, we give it simultaneously to Dr. Patel and his counterparts in Cheyenne. So I think it's probably best to have public health decide how they want to notify people. I don't think that's unreasonable.
For the community of Wright, should they seek treatment in Gillette, or is the Wright clinic prepared to care for them?
I think, you know, what we've learned about these cases, and when I say what we've learned, this is information I'm giving you that's not even in the literature yet, but comes from these gentlemen who are the recognized experts. There are now ways to, it appears that some of these may move and be able to be tracked. As I give you an example, Dr. Musser's group studied just a few years back an interesting situation where they had a few scattered clusters in Canada. And someone said, you know, these clusters seem to be, it's unusual because normally it's just sporadic and not common. But what they did was they sent those organisms to Houston for typing in Dr. Musser's. And I think it'll help the community feel more comfortable about what we're doing as well. The standard published, what do you do in this situation, that's been done, and in my opinion, that all happened appropriately. But Campbell County also would like to go beyond that. So, and I agree with them 100%, that's my recommendation as well. So we're acting on information that, you know, is quite new information.
You said that the case was first identified in about mid-August?
Yeah, August, September is the timeline here.
Okay. Well, when was the first case actually identified as such? The newspaper had asked about first week of September if any of these cases existed at the hospital or had been treated, and we got a no answer. And
I understand your concern. You know, I'm not really, I'm aware of that, and I've seen the, you know, press releases and so forth. I wasn't really involved in that, as I'm not privy to what happened there. I don't, after looking into it, I personally don't feel like there was any attempted, you know, cover up or any attempt to, on purpose, mislead anyone. I think it was unfortunate the way it happened, but I'd have to refer you to Ms. Clark or administration, because I'm a doctor. That's kind of what I do. But I understand your concern. You know, the public needs to know what's going on, you know, within HIPAA guidelines, and so I think Karen or someone else can handle that question for you. I mean, now or later or what?
now, if you'd like, or later, I guess.
Well, that's entirely, you're the questioner, so.
Might as well be now.
Yeah.
Okay. You want to?
Sure. And as I said before, we acted on the best information that we had at the time, and unfortunately, as time went on and more review and investigation was done, the answer changed. So we appropriately reported when it did change and when those cases were confirmed, and have been reporting that to you and to the appropriate authorities.
Yes, sir.
You say that it didn't originate here. Do you mean here in the hospital? It originated out in the community?
These, yes, it originated in the community. These people came to the hospital with infections, evidence of infection. Now, they were cared for here in the hospital, no question about that. They were cared for within Campbell County, but they didn't, there's no evidence that they originated here at the hospital. That just, and the other thing, if you look into the literature there, when I say necrotizing fasciitis, there are two different types really. Well, there's several different types. It's kind of a type 2 what we're talking about, and that type 2 is group A streptococcal necrotizing fasciitis. There's a type 1 that can originate in hospitals in post-surgical patients. This is not related. These are not the same thing. The cases we're talking about were all group A strep type 2, and they tend to occur in communities. They just pop up. Someone may get a little wound for whatever reason. Oftentimes, well, almost always the organism has to be a more virulent or more aggressive organism, but also they can occur in people with underlying medical problems. And of course, those people have a higher mortality. It'll tend to have a reasonably high mortality, particularly in older individuals who have, other diabetes and peripheral vascular disease, things like that. But no, there's no evidence in my mind, and I think everybody else agrees that they originated in the hospital. These were not type 1s. You can see post-surgically. These are type 2s.
After the cases were first identified, what were some of the precautions that the hospital took to make sure that the bacteria wasn't being spread?
I'm sorry, that the bacteria wasn't being
spread. What were the precautions once you all identified it?
Yeah, those are standard precautions that you would use with any infection. And so that didn't really change or alter, because if you look at the official CDC recommendations, they will describe standard precautions. After a patient's been in a room, the room is clean. After a patient's been in the OR is, I don't know what you call it, sanitized or decontaminated and so forth. So, but I will tell you that in the future, based on new information, some of those recommendations may change, but we have to wait on CDC to review all those information. And it may change because of the close contact issues. But that'll have more to do really with hospital personnel caring for them and for close contacts. But the current recommendations, and here they followed standard protocol. I'm not aware of any breaches of protocol, and I don't think unless you know of any or anybody else does. No, these cases are very unfortunate. Serious disease is very unfortunate. But I think in terms of the way it was handled, from the physician's standpoint, I think the care was good. I think it was appropriate. And I think what we're continuing to do is actually appropriate above and beyond. So, but I think it's important too. And certainly down the road, as we get more information about what we're doing, I'm sure, public health, it's public health. I'm sure they'd be happy to share information on the data that we'll be getting. I don't really know how long the typing takes. It's a laboratory procedure, and it'll involve cultures from close contacts as well, in addition to the organisms from the original cases. But I don't think we're talking more than a matter of weeks. Dr. Patel, do you have any comments? You're the
No, you gave most of the
County-
information.
county health officer. Members of the board?
I'd speak.
Procedures.
Oops.
Yes, I'm George. So I'm George Dunlap, hospital board member. I'm not here representing the board. I'm representing myself as a board member. This is very unfortunate. I think I have to apologize because I'd heard about this prior to Karen's comment that it didn't happen. And I personally allowed it to be told that way. I believe Karen, knowing her personally, would not in any way mislead the press. I personally was criticized for knowing too much about what goes on at the hospital at the last board meeting that I just took promise. By growing up in this community, I had a lot of people tell me what goes on. I find out a lot from what happens, from employees, from people in the community. And we knew about this, and I personally blew it because I allowed this to happen and not stand up because I didn't want to be criticized and belittled by Mr. Bronson again. And I believe if Karen would have known, there's no way in hell she would have lied about it. So she, I believe, did not lie. I believe she was given bad information. Somebody knew because I knew. And I was told who in the administration was told about this, and it's wrong. And as a board member, I let the public down, and so did, I'm sure other board members knew about it too. I do not know that, but I definitely knew, but that's not worth the criticism. This board, we have to stand up and do what's right in the community. And to stick our head in the sand is wrong, and I did that. I apologize to the community.
Any other comments?
You have other questions for me? We have, the administration is here, Karen is here, I think we have Director of Nursing here, our pathologist, Dr. Woodard, is here. Help me any way we can.
What is the procedure for notifying the state? The state epidemiologist said this morning that they knew about it in the middle of August, about the first case, and had set it aside because it wasn't a reportable communicable disease, but they knew about it. And the subsequent cases, how were those reported, and what's the procedure for that?
Yeah, good question. The way do you want me to take this, Dr. Patel? There are lists, at least in infectious diseases, there are a list of infections that hospitals are required to report to the state health department. In other words, there are lots of infections. People are admitted to the hospital all the time with pneumonias and urinary infections and wound infections that don't get reported because they don't need to be reported. Related to group A strep infections, there are only really two categories, and one, is Veronica here?
Yes.
Oh, great, okay, there you are. You report to the state what are called toxic shock type infections related to strep or others. Isn't that correct?
Yes.
And the, infection control, Veronica's the infection control nurse. She did that. The other category of group A strep infection that may relate to these cases is what's called sterile site infection. Sterile site infection means, like, for instance, if you grow this organism out of the blood and it's a group A strep, that is reportable. So this was a sterile site infection, and that was reported, is that correct, as well?
Yes, I did report all three cases.
Yeah. So, and then the state, the state.
The first time we released it is what we knew at the time. All these situations are dynamic, they develop over time, and as we got more information, I think we're pretty forthcoming with that information. So beyond that, Ramsey, as far as dates and every individual thing that we knew, to be quite honest, I'm not in that loop. That's not normally what I do, as you know, but if Deb or Veronica or Karen, whoever might be best to respond to that as far as some chronology of events, that, I think we can tell you what we know without, as Dr. Brown has very adequately explained, revealing anything about the patients themselves and any identifying information. So one of you guys would like to address that issue as far as what we knew when we knew it? Yeah?
Ramsey, I would concur with what Andy Fitzgerald just said. At the time that first press release was made by the hospital and the information was published, we certainly went on the information that we had, and I think it was later on as further confirmation came on just the extent and the severity of what we had. But at the time, again, certainly the hospital was being as transparent as we could be, and we certainly went on what was in the chart and had been confirmed at the time.
I think it's important, Dr. Brown, just to reiterate, that first case was not necrotizing fasciitis, is that correct?
That's correct.
Okay.
It was a very serious life-threatening infection, but it was not necrotizing fasciitis.
Did members of the media hear that? You want to restate that with the microphone?
It was not, clinically, it just did not look like necrotizing fasciitis. It was a very serious group A streptococcal infection, life-threatening, but it was not, the other two cases were necrotizing fasciitis. All three were very serious, no question about it.
The other two cases, were they already in treatment when, by September 6th, 7th?
Nate, can I have you hold on? Dr. Brown, would you take the podium again? Would you restate that, please?
Were either or one of those other cases treated or in treatment by September 6th?
They were sequential, so the first case popped up, the non-necrotizing fasciitis case popped up. I think the interval is in the kind of 10 to 15 day range, and then the next one, and then the next one, with the same kind of range. The only connection that we can see is in the two necrotizing fasciitis cases where there was an obvious close contact regularly, and that, from the infectious disease and epidemiologic standpoint, that made sense, because we do know, although it's uncommon, that periodically there can be close transmission.
Is that second person still in treatment, and what's the condition or status?
I really shouldn't, I'm not supposed to give identifiers and things like that, so there's been one death. I mean, I can tell you that, and that was also announced by the Dr. Murphy, the state, epidemiologist.
Anything else?
There's a public, hospitals asked us to do a public forum Friday, I think, at 2? Noon. Oh, noon.
Yeah.
And I think the location may be changed, but the hospital will be able to tell you about that. I'm around, so. Yes, sir.
I've got one more question. You say it was two people that were in close contact. Is there any way that you could research that back? Maybe you addressed this earlier, but to find out at what point maybe they came in contact with this bacteria?
You mean when the first one?
Well, no, just when that person may have come in, transmitted it, I guess. Maybe cut himself or whatever on something, or, you know what I mean?
Well, one of them happened, evolved and became obviously sick, and it was an interval later that the second one became sick.
But that first person, you couldn't tell if it was like, I'm thinking, if it came from
Yeah,
a
I'm sorry, I'm
certain
not getting
place.
you.
Did it happen at a certain place? You know what I mean?
Like a locale?
Yeah, like in the woods, they were out camping or anything.
Can't answer that now. I don't know.
Okay.
We're, as part of this, these things take time, but we are kind of trying to do some tracking and so forth with the blessings of the state. The state normally doesn't do that because it's not normally indicated, but we think it's important, so it's being done.
Okay. Thank you all for coming, and if we do change the location of Friday afternoon's forum, we will let you know. We're still working on whether that's going to be here at the hospital or at some other location, okay? All right, thank you all so much.